recording this meeting and broadcasting it online live as we speak. Few announcements. This is to let you know that Martin Spencer has stepped down from his role as non-executive member. We'd like to thank him for a significant contribution to the board as the chair of the Audit and Risk Committee, and we wish him well and a speedy recovery from his current ill health. Bob Alexander, previously an associate non-executive member, has been appointed as a non-executive member, and we congratulate him on his appointment. Bob will be chairing the Audit and Risk Committee. You will have seen from the report on changes to the governance structure of the board that a number of board members will be stepping down from their roles after this meeting, and I'd personally like to thank them for all of their significant contributions to the board over the last 3 years. And I know that through their roles within their own health and care forums, they will continue to impact upon the delivery of health and care services across South West London, and we look forward to continuing to work with them, although not as part of the board. Unfortunately, we cannot take live questions from members of the public, but members of the public have had an opportunity to submit questions in writing before the meeting. As our format for meetings will in future be online, public board meetings, we will continue to advertise the facility for people to ask questions in advance. We have received apologies from Vanessa Ford, Councillor Andreas Kirsch, James Blythe, Hannah Doody, and Matthew Kershaw. I can confirm that the meeting is quorate, so we will proceed with the meeting. The next item on the agenda is declarations of interest. We have published a declaration of interest back with this paper, and members are asked to confirm there are no additional conflicts of interest that they should have declared. We note the register of interest. On to the minutes of the meeting on the 19th of March. Can I check that people are content to approve those minutes? I see no dissent, so I take that as approval. And just to note that the action log has been updated and all actions from previous meetings have been closed. Move on to decisions made in other meetings. If I could go now to Ben Luscombe to speak to the item. So Ben, decisions from other meetings.
Thanks, Mike. The board has had 2 meetings since our last public meeting. We met on the 19th of March, where we discussed the 25/6 operating plan. The board approved the procurement of a community eye care service contract, and it approved a modification to the Royal Marsden's contract for cancer system development funding. The board also met on the 26th of March in a Part 2 meeting, and it approved the operating and financial plan submission for 25/6 to NHS England. It approved 25/6 capital plan for the system, and it approved the ICB's budget for 25/6 and also the better care funds for 25/6. That's it. Thanks, Mike.
Thank you, Ben. Any questions in relation to those items? In which case we'll move on to Quality and Performance Oversight Committee and the terms of reference. Having conducted a review of the current terms of reference committee effectiveness survey, I'm going to ask Masood to briefly present the report. Masood.
Thank you, Chair. The item presents the annual review. No amendments are proposed at this stage. Some of the key themes from the recent effectiveness survey have been shared, particularly around membership alignment with transformation oversight and opportunities to streamline reporting. It's felt that the current terms of reference remain fit for purpose. However, we do anticipate there may be a revision later on in the year in light of forthcoming changes to ICB function. So welcome your approval, current version, and any reflection on the feedback themes. Happy to take any questions.
Masood, thank you very much. Any questions for Masood, or can we move straight to acceptance, approval of the recommendations? We approve the recommendations received. Thank you very, very much.
Thank you.
Moving on to item 4, change to the government framework for South West London ICB. I'll hand back to Ben Luscombe. Ben.
Thanks, Mike. I'll be brief because we don't have a great amount of time, but I'll give you a quick overview of the paper. So the paper sets out changes that we need to make to the governance structure of the board as a result of the publication by NHS England of a model ICB blueprint, and also our submission of the 25/6 operating plan. The paper is split into 3 sections. Outlining the different areas we need to make the changes to. So the first part of the paper sets out changes we need to make to the ICB's constitution to reflect the changes we need to make to streamline the board's membership, principally. It also picks up a couple of updates and some formatting changes in there. We're also proposing to add an amendment to give the chair of the ICB the power to extend board member tenures by up to 12 months, given the current uncertainty around the future structure of ICBs. This provides the appointment process for some board members is quite onerous, so this provides us with an efficiency saving over the next 12 months, and then we can see where the ICB goes in the future. The amendments are all being made in line with the legal and constitutional rules for making the amendments. The board are asked to agree and recommend these to NHS England, and it's NHS England's final approval of the constitution and these changes. The second part of the paper then outlines a number of logistical changes that we're making to the board. So, for example, the fact that future boards will be online and that we're moving on a quarterly basis for our public boards going forward. And then the third part of the paper sets out the revised assurance framework that we are putting in place to provide board assurance on the delivery of our in-year 25/6 operating plan and our work to meet the deficit control total. So I won't go into any more detail on the paper, Mike, but I'm very happy to take any questions.
Thank you, Ben. And I think we'll take it in the 3 parts that you suggested, which are looking at the proposed constitutional amendments, changes to the board, and changes to the running of group arrangements for the board, and then the governance structure and financial recovery. So first of all, the proposed constitutional changes to the board, and I think I've seen 2. Well, Elisa, your hand went up and then down, and Sarah, your hand is up. So can I go to Elisa first?
Thank you. I confess I don't know if my statement is relevant to the first part of the Constitution, but I just wanted to say, first of all, thank you very much, Chair, for the opportunity to speak. So I represent the 6 local health watch organizations in Southwest London, and we are one of the groups that have been asked to step down from the board. And we're very concerned about this proposal. We currently sit as non-voting observers, and it's our statutory duty under the Health and Care Act 2012 to ensure that the voices of patients and the public inform decisions about health and care, and our seat on this ICB is key to fulfilling that role. So our presence provides independent scrutiny of how the ICB involves the public and brings forward real-time insights from our communities. This directly supports the commitments outlined in the Model ICB blueprint, especially to draw on the community feedback, to evaluate our commissioning decisions, and to build a deep understanding of local needs. So at a time when the ICB is taking on the role of strategic commissioner, and the ICB is under serious financial pressures, we believe that it's more important than ever that decisions remain transparent to the public and are grounded in the experiences of our 1.5 million residents. And we believe removing HealthWatch risks weakening that connection with the public, and we strongly urge the board to retain us as participating observers so we can continue to support open, informed, and accountable decision-making. Thank you.
Elisa, thank you very, very much, and I do understand the points that you're making. And I'll ask Ben to respond to those at the end of this session. Sarah.
Thank you very much. Just want to support what Alisa was saying. As you know, I'm the director of the South West London VCSE Alliance, so I represent the 5,000 and more voluntary sector organisations in South West London. 2 points. One is about the time frame. I think the time frame for this decision was too short. We were told about a week ago, and I see on the papers that this new model is being approved today. I mean, in South West London, we've got a long tradition of partnership, and we spent many years working hard to build the trust, the co-design. And I think, as Alisa was saying, that the blueprint points to co-design and transparencies across. I believe, to be honest, that your commitment to have the Alliance on board, on the ICB board, was reflecting your commitment to work with communities with that experience health inequalities, and your commitment to reduce health inequalities in these communities. So I don't particularly agree on the decision to take off the Alliance off the board. I think we are your means to engage with the qualitative data, with the why of your data, of your business plans. And I think you're going to miss out on this if you do that. Thank you.
Thank you, Sarah. Shannon.
Thank you. In addition to the comments made by Healthwatch and voluntary sector representatives, I also wanted to highlight concern from a local authority perspective in terms of stepping down of the borough leads. Particularly as a director of public health, I think that, you know, the input and the opportunity to influence the decisions made at the South West London footprint have been really vital, and I think would have continued to be vital in terms of the new strategic commissioning responsibilities, of which I think, you know, public health is absolutely key to supporting some of those decisions and making a contribution to that. So I just wanted to highlight those concerns around the decision that has been made. Thank you.
Thank you very much, Shannon. And Callie.
Thanks, Chairman. So I just want to support the reduction in the size of the board. I think that's really important. We're in a very difficult environment at the moment, so some opportunity and a lot of risk. So I think the idea of having a much smaller, more manoeuvrable board is right. But I think alongside that, it's just making sure that those touch points exist. And so particularly with my specialist services hat on, I would wish there to be a regular touch point for a body like RM Partners representing cancer improvement across the patch to come into the board, because mental health and acute partners will remain. So I think it's a good idea to reduce it. I think it's rational and sensible, but then I think there is a requirement to really reach out and make sure some of these bodies that aren't directly represented are able to link with the board regularly and properly on important business for patients. So, you know, my ask would be particularly about RM Partners having a regular touch point with a newly reformed board.
Callie, thank you very, very much. And I'll make a couple of sort of quick observations before handing over to Ben. The first of it, Alisa, is we want Healthwatch to continue to work closely with us. We need to find other vehicles and other places that we can do that effectively. And with your permission, I will ask Ben to look into ways in which we can ensure Healthwatch's continued involvement in the work of the ICB, albeit not with board membership. Sarah, I think your points about timescale are well made. Sadly, the timescale has not been set by us. It is actually just 8 weeks ago that the announcement was made to reduce the size of ICBs by 50% in the case of South West London. It's actually considerably more than 50%. And our requirement is to make those decisions rapidly, including, as reported today by Ben earlier, submitting a template for the ways in which those reductions will be made by the end of this month. So fully understand your concerns about the timescale. I think they're more widely shared. But again, I will also ask Ben to work with you to make sure that our ongoing commitment to the VCSE sector is embedded in the way in which we move forward, albeit not with board membership. I am aware that you wrote to Katie and myself either today or yesterday, and we will respond formally to that, but I would hope that we can also have a conversation with you alongside a formal report. And Callie, thank you very, very much for your comments. Again, we need to make sure that we have got those touch points with the key partners across the system, and their engagement in that. And again, I think we will work with, we would want to work with you, Callie, to ensure that they're appropriate and timely, and they inform our work moving forward. I will go to Katie now, and then I'll come back to Ben for final comments on the basis I've given you quite a lot of homework, Ben. Katie.
Thank you, Mike. I think it was just really to reiterate some of your points, that actually attendance at a board meeting does not make meaningful engagement. We all know this, but I think it's really important to make that statement into the room. And actually what we're not moving away from is our absolute commitment to meaningfully engage and make sure that South West Londoners, through the variety of different organisations and alliances that represent them and speak on their behalf, are part of the active conversation that supports decision making. This is a bit of our transactional mechanics, if you like, in terms of the size and scale of set piece meetings, and we are looking to pull back from a whole variety of set piece meetings because of our need to reduce the infrastructure that supports them. But this is not stepping away, just to be absolutely clear, not stepping away from an absolute ambition and desire to continue and strengthen our engagement and the conversation around all aspects, whether that is Health Watch, VCSE, local authority partners, specialist commissioners, specialist providers. That is core to the function of a model ICB. It's just the way we will do it will be different. Thanks, Mike.
And Katie, it's probably worth saying something to Shannon about the arrangements you've put in place with our local authority chief executive leads.
Yes, I have put in place a dedicated fortnightly meeting with all 6 local authority chief executives, which will engage primarily at the moment on the changes around model ICBs, because that's obviously of very material interest, but we'll continue to morph, and we will work out how and what is the most meaningful way to engage with local authority colleagues moving forward as we head into being a strategic commissioner rather than the broader roles that current ICBs have.
Thank you. And Shannon, you kindly invited me along to the meeting at the South West London DPHs. And we would want to seek other means of continuing to have that regular engagement with our Director of Public Health. We see them as a vital tool, particularly in strategic commissioning around business intelligence, needs assessments for our population. So again, sort of echoing Katie's comments, participation in the board is not necessarily the best way in which we can ensure your meaningful engagement and contribution to the ongoing work of the ICB. Farah, I'll come back to you and then I'll give final words to Ben.
Thank you. Just 2 points following what Katie was saying. And one is, yes, I agree, the ICB board wasn't probably the best platform for engaging the voluntary sector. However, it did give visibility to the voluntary sector, and also kind of allowed the voluntary sector to have those important side conversations that actually brought us, together in different rooms. So I'm really keen to see what the mechanisms will be for future engagement. We know that the sector can input on commissioning, specifically now that you've got more of a role in strategic commissioning, and also health inequalities, as well as this healthy neighbourhood theme that is emerging. So we're really keen to be, consider key partners for that.
Thank you, Sarah, for that offer. And as I said, we will ask Ben to work with you to make sure that we can agree the appropriate ways. And you're absolutely right. Neighbourhood health services are going to be at the heart of the way in which we develop services in South West London, and the voluntary and community sector is a key part of our capacity to deliver that effectively. Ben, final comments in terms of steps for following up, please.
Thanks, Mike. And just to echo whatever I think between Callie, yourself, and Katie, you covered all the points that I was going to make. So I think for next steps following this meeting, we need to submit the constitution to NHS England. I've been told they will turn around approval of that quickly. So really following this meeting, we will almost immediately implement the steps that are outlined in the paper, Mike. And indeed, if you take something like the financial assurance around the in-year delivery of a plan, the first meeting of the financial recovery group is going to happen this afternoon, and we'll start reporting that through seminars and the next board. I think that's probably everything else has been covered, Mike.
Great, thank you. So in the minutes, if we can make sure we note those reservations and commitments from the ICB in relation to those comments. And I'm assuming that people are content for us to move forward with the constitutional amendments, note the changes to the running arrangements of the board and the governance structure for the financial recovery programme. Thank you. We will move on to item 5. And I'm going to pass across to Helen and Jonathan to talk us through the operational plan for 25-26. Previous drafts have been available, but this is a somewhat different draft from our last submission.
Thank you very much, Mike. I think I'll start and then Helen will join to cover off a number of the financial aspects of the plan. As you allude to, Mike, this isn't our first opportunity as a board to reflect on our operating plan. We have done so in meetings on a number of occasions in March. What I would want to do at the outset is start by saying an immense thank you to all the partners on the call for the work on this. This has been a particularly challenging planning round. I know we say that every year, but it's certainly very true for this particular year. And whilst we're not alone in the NHS or indeed in the wider public sector in terms of facing up to that scale of that challenge, given the financial constraints under us, it's important, I think, to acknowledge how well and how collaboratively we've worked to produce a plan that delivers the best for patients in southwest London. So the plan or the national expectation set out by the government and by NHS England focuses on the key shop windows really for the NHS that matter to the public, about reducing waiting times for planned care, improving access to urgent and emergency care, improving access to GPs and to the wider primary care community, improving mental health crisis services, and particularly for children and young people, improving mental health services more generally. And section 1, there are 3 sections of this paper, but section 1 of the paper sets out our plans in summary form to achieve that. I'm pleased to say that in all those areas, we're planning to meet the objectives set for us and the expectations and targets set for us by NHS England. The one exception being the planned growth in the number of planned care patients treated within 18 weeks. We are not planning to deliver. That's partly because we already perform amongst the best in the country against those referral to treatment time targets, but it's more so driven by the financial challenges that we face as a system. But nonetheless, we will remain one of the better performing ICBs in the country if we deliver the expectations in this plan, and to reiterate in all other areas that we're planning to achieve what we've set out. The risks, and they're summarised in the both in the main paper and the summary paper, but the risks are really significant, and I think it is just worth mentioning or reiterating those to the board. So the scale of transformation required here is really immense to deliver the reduction in general and acute beds that are planned, improve the average length of stay for mental health services, improve elective care productivity. I think it's worth noting that we recognise that the risks around that and are very carefully thinking about both the equality and equality aspects of our plans and of undertaking a full review of those plans to ensure that we're aware of the impact they have on patients and mitigate them wherever possible. The paper also sets out against elective care the need to balance our achievement levels with the financial envelope available to us. It notes the scale of workforce reduction and the fact that redundancy costs have not been assumed in the plans associated with the reduction at this point in time. It sets out some risk relating to our capital plan, and also the risk as ever of unknowns occurring, often linked to pressures that emerge through the winter period, but there may be other factors too. So those are some of the key risks that we spent some time in detail discussing in the board assurance framework conversations or board assurance statement conversations that we had in March. You can see we've updated the commentary section in the sections relating to the board assurance statement to reflect the progress we've made so far in those areas, and you can see the overall view that we are seeking the board's support to ratify the plan that we've agreed with NHS England. It's worth noting late on Friday we also received a letter from NHS England confirming their view of the close down of the planning round, which is timely given we're already at the end of month 2 and frankly need to move into delivery phase. So that's probably all I wanted to say, and then Helen probably want to talk about section 2 of the paper, which talks about the financial plan in a little more detail. Thank you.
Jonathan, thank you for that overview. And whilst we have only just received confirmation from NHS England on the close down of the plan, I'm pleased to say actually we have already got on with delivering it, as you know, and a big thanks to our acute trusts for the reduction in beds which have been achieved in April, including before Easter, which I think is heroic. But so a big thank you to them. Helen, section 2.
Sorry, my computer decided to tell me it wanted to restart itself just at that precise moment. So thank you. Yes, as you know, the difference in the finances from the finance seen is the fact that their plan agreed with NHS England was a break-even plan, which had a 7.3% efficiency in it. Within the paper, you can see the profile of the plans for the different organisations across the system. Thank you for everybody for all of their hard work to move that. Within the position, the ICB budget has remained the same in its spend as you had previously seen. Unfortunately, the paper doesn't seem to have been circulated, so we will circulate that alongside so that you can see the final budget for the ICB as part of that system-wide position. But happy to take any questions.
Thank you, Helen. And it's encouraging to see that we have hit the target at the end of month 1, which is not something that all of our colleagues in other parts, in other ICBs have achieved. Any of our colleagues in other ICBs have achieved. So again, well done on that. We need to, Anne.
Can I just ask a quick question of clarification. The 108 deficit support, has that been agreed?
Yeah,
So
as part of the plan. Sorry, Helen, do you want to answer that?
It has been.
yeah, sorry. So the 104 as part of the plan has been agreed. However, new systems and ways of working have been introduced so that you have to ensure that you are on plan to be able to earn it for the next quarter.
Yeah.
So it's
yeah.
a bit like the old regime of PSF. So it's like that. So we've been confirmed that we are receiving that allocation for the first quarter, and at month 2, NHS England are going to do a review to determine if we can receive it for the second quarter, and it will sort of progress like that throughout the year.
Yeah. Okay. Thank you.
And a really good question, because clearly that would be a business critical issue for us if the deficit support funding was not available. Can I get the formal ratification from colleagues that they are happy to sign off the operating plan? Thank you very, very much. We'll now move to the draft corporate objectives 25-26. Karen, over to you.
Thank you very much. So as you've just heard, we've got a challenging year ahead of us, not only to deliver the programme that Jonathan and Helen have just outlined, but also to reshape and redesign the ICB to become a strategic commissioner so that we deliver the new national model for ICBs and also reduce costs. And therefore, we've been talking in the management team about our focus and want to recommend to the board today 3 corporate objectives to make sure that we deliver the essential things that we need to deliver and that we focus all of our staff on the things that are going to make a real difference this year. Those 3 objectives are set out on page 109, but the first is to develop and start to implement a clinically led strategic plan that will deliver not only the needs of our populations as they change over the coming years, but also return our system to a financial balance. The second is to redesign the ICB to become a strategic commissioner and deliver the new national model for ICBs. And the third is to deliver the plan that Helen and Jonathan have just outlined, and in addition, oversee both the performance and safety of South West London. We have designed a series of actions and outcomes to support the delivery, and we're suggesting that the management team oversee the delivery of those on a monthly basis as we move forward to make sure that we deliver everything that we expect to deliver this year. And I'm therefore asked the board to agree those corporate objectives to make sure that we deliver on the things we really need to do. Subject to the board approval, then we would then write those into everybody's individual objectives throughout the organisation so that that delivery cascades throughout the ICB. Thank you, Chair.
Thank you, Karen. Really clearly stated and really good set of 3 clear objectives. Sarah.
Thank you. Thank you very much for this. I wanted to make 2 comments, and one is I personally find the corporate objectives a bit clinical, and I find they leave little space to prevention. So I wanted a bit more reference to prevention in there, and also with reference to objective 2 in particular, which is where the voluntary sector could make a very good contribution. I wanted to see a bit more about communities that experience health inequalities and the services the community use within the voluntary sector in there. Yes.
So before coming back to you, Karen, I'll take any other comments. Like to see Shannon.
Thank you. In terms of the sort of first objective around the strategic planning, I think, Mike, you'll be aware when you visited the South West London Directors of Public Health, we discussed briefly around needs assessments. So really it was just to highlight an offer of support, because obviously conducting needs assessments and trying to assess the level of unmet needs in the population is regular business for local authority public health teams. And we would imagine that you would lean towards a lot of the work that has already been done in local authority as opposed to replicating or duplicating it. Thank you.
Shannon, thank you for that offer. And I have reported that back into my colleagues at the ICB, and they are gratefully receiving it. And it will form part of the scope for the company that we're working with to actually work with DPHs. Karen, over to you for comments in relation to Sarah's point and Shannon's point.
So just to say to Shannon, absolutely, thank you. You're in our plan, Shannon. We will come and talk to you about how we make the most of all the massive amount of expertise that all of you have. In relation, I'll just have a look at the wording and the outcomes about prevention and health inequalities, but particularly that is the purpose of the long-term strategic piece of work, to look at not only the services that we're going to need, but also how we're going to prevent ill health. So I'll just see if we can pull those things out a little bit more.
Great, thank you for that, Karen. Sarah, Shannon, thank you for your contributions. People content to approve the draft corporate objectives? I see no dissent, so thank you very much. We'll stay with you, Karen, so keep your microphone on, because we're going to go to intensive and assertive community mental health services. And I think you're going to be joined by Lucy for this.
Yeah, Lucy's here, but just before Lucy takes over, I just wanted to kind of put this into a little bit of perspective. So this provides an update on the system review of the intensive and assertive community mental health services that are available in South West London. And as board members may remember, we presented a board paper in January in response to NHS England's request that both ICBs and NHS Mental Health Trust report on the delivery of those services. And just to remind that followed the publication by NHS England in February 2025 of an independent investigation into the care and treatment provided to valdecoxib by NHS services. And what you have in front of you today is a further update, which we're required to do by the end of June, to show our assessment against the national publication, but also our response to it. But I'll let Lucy talk through a little of the detail.
Thank you, Karen. So as Karen has said, we first came together in January 2025 in response to the incident at the valdecoxib murders in Nottingham in the summer. Through that assessment, and obviously John, myself and other senior members of both the ICB and the Trust were involved in going organisations on top of their own internal assurance to be clear that the right policies were in place for partners who require intensive assertive community treatment and are resistant to accessing treatment under the conditions that were set out. And I think at that point in time, we agreed that we had a level of assurance that we were reflecting the right policies and procedures were in place, but that assurance would always be limited. It is not possible to have full and comprehensive assurance for every patient, for every situation at any point in time. And I think we acknowledged that in the meeting. Subsequent to that, as Karen has into the events in Nottingham that had 12 recommendations. Some were targeted at NHS England, some at trusts and some at ICBs. And what we've been required to do is bring a further progress report to this board that sets out not just how we have done on our original assessment, but how we're specifically meeting the additional tasks that arose from those recommendations. So as is outlined in the report, there has been really significant progress. There's been progress around risk assessment, progress around joint discharge planning, progress around multi-agency working. And there were some differences around South West London St George's, who service 5 of our boroughs, and SLAM, who service Croydon. There's also been targeted work around working with families, working with patient experience, and also doing out-of-area placements. There is a recognition in the paper that, again, assurance always has some limitations because it's not possible to account for every single possible expression of managing very, very complex patients in the community who are treatment resistant. What we are confident of is that the programme is happening at a reasonable pace and going in the right direction. Standard, also turn off my camera. Been some investment through the MHIS standard in both services. progress is still not complete because we're expecting to see that investment take effect in year. And we're happy to come back and provide further updates to the board if people think that would be helpful.
Thank you very, very much. Thank you for the report. So we're asked to note the report, note the ongoing actions underway to improve intensive care. And Lucy, thank you for your offer to come back and give us updates. We will look at the timing for that, if we may, to make sure that we keep sight of this in an appropriate and timely way. Assuming everybody's happy to approve the report. Thank you. We will move on to Katie, and item 8, which is the SMT and organisation report. So, Katie, to you.
Thank you, Mike. I would take the report as read. What we're trying to, it's a bit of a move from the old model around chief exec reports to really try and cover off items of business that are discussed or things happening across South West London that haven't been notified to the board through any other channels. So there's lots of information in there. Happy to take any questions that people might have.
Katie, thank you very, very much. And I think the new format is really, really helpful. So thank you for that. Any questions for Katie in relation to her report? See no questions, Katie, so we will move on. We're now moving on to the section of the board meeting, which is based upon our committee update and report. So for our first item, I'd like Jamal, our chair of Finance and Planning Committee, and Jamal will hand across to Helen for the finance report.
Thank you. Just a brief summary from me. I guess we had the last F&P meeting was on the 30th of April, 25. I guess the summary would be following huge efforts and focus across the entire system. Both the ICES and the ICB delivered to financial target subject to audit as a highlight. So that was a huge effort to get that to where it needed to be. We discussed the capital plan and the allocation risks attached to that. And the committee approved the plan, which is going to be published at the end of June. And we reviewed a number of business cases and contracts according to our ICB governance. And then the final part was we just also reviewed, following the ICB new blueprint, what impact that might have on the F&P committees going forward. But I'll pass over to Helen for any further detail.
Thank you. As Jamal said, the month 12 report went to the F&P committee and is within the pack today, which shows a £500,000 surplus to plan, but is subject to audit the system. Within that, the ICB was on plan for delivering its £3.1 million surplus. Key things to know are we successfully got down below the agency cap, and I think a lot of hard work happened across the system, but we didn't necessarily reduce the number of hold times in line with our original plan expectations, and the delivery of our savings program was more non-recurrent than we had hoped for, and therefore that obviously raises the challenge for 25-26 as we go forwards. The only other key thing I'd like to mention is we remained within our CEDAL envelope as a system, with some slippage where leases were managed to be negotiated cheaper than was expected, and therefore there was a reduction of spend against our IFRS 16 capital. And there was some slippage on national programmes, as we recognise there's been a lot of change and churn in those over the year. But happy to take any questions.
Was the bread left over?
Thank you. Any questions for Helen or Jamal? No? Thank you. We'll move on to quality and performance. And if I could ask Masood, our non-executive chair, to introduce this item and then hand across to Elaine, and from Elaine to Jonathan.
Thank you, Chair. I'll take the papers as read. The committee met on the 9th of April 2025, and I think I'll pass over to Elaine to give you an overview from a quality perspective.
Thank you. Just sorting out the mics here in our room. Thank you. You'll we had a deep dive on discharge planning and processing, which obviously impacts significantly on both quality, patient safety and performance. You'll see the quality report, which is attached with the papers, where we look about the continued challenges with IPC, in particular norovirus, COVID and flu in the period. Patient flow is a significant challenge, which we continue to talk about and look at and note improvements in the work around that. We had a deep dive on special educational needs, and we talked about issues with medical needs for children in schools, and recognise there's some more work for us to do around an increasing request and demand for medical support for children in schools. So that work is underway at the moment. We talked at length and approved policy and process around our quality impact assessments, and given colleagues conversations about finance and our planning, that's important. Again, we have some deep dives and some assurance around the QIAs and the risks and mitigations coming to our next Quality and Performance Committee. We received some assurances around some of our medicines, safety and management as well. Happy to take any questions.
Thank you, Masood and Elaine. Any questions for Elaine? No, in which case, can we pass across to Jonathan? Oh, sorry, Sarah. I just saw your hand go up.
Okay. It's not a question as such, just a request. I would be really interested in the deep dive reports on both the SEN and the discharge, if that is possible. I don't know if kind of, you know, a report has been produced, a kind of lengthy report has been produced on those, from those deep dives or not.
Elaine, can you respond to Sarah?
I can, yeah. The deep dive on discharges was across all our providers, and will be shared with colleagues in local authority. The SEND paper was more about the statutory duties for SEND and an update of where all our local authorities are, and that should be in the local authority partnerships. So I'm sure that we can share that with you as well.
Thank you.
Thank you very much. Jonathan, performance.
Thank you very much, Mike. So again, I'll take the paper as read. The summary highlights 3 areas of progress, and I would particularly want to note we were set an expectation of 78% of patients being treated within 4 hours who arrive at our accident emergency departments in March. It was a key target for the NHS, and we exceeded that. We delivered 79.6%. So I think quite important to note that and say thank you for everyone who worked so hard to deliver that. Also to note our ongoing strong integrated urgent care 111 performance and the progress made at reducing out of area placements for adult mental health patients, which I think is important and a significant measure too. In terms of the areas of challenge, there's a strong crossover as ever with those identified in quality. So flow through hospitals and timely discharge, hence the reason for the deep dive that Elaine just mentioned, remains a challenge for us through the winter months. The issue that we've talked about here before on patients who wait frankly too long in our emergency departments before being found an appropriate bed, and also slight growth, though from a very low base in comparison with others, in the very long waiters, patients who waited more than a year for access to elective treatment, heavily influenced by winter pressures through the sort of December-January period. So those are a few highlights, both positive and less so, and happy to take any comments or questions as ever.
Jonathan, thank you for that. Any questions for Jonathan? Oh, sorry, Anne.
Yeah, just a quick question, just a theme I was just reflecting on that's going through a number of the papers is the length of stay of mental health patients, obviously then contributing to the non-availability of beds and what that's meaning for A&E departments. I think it says somewhere in the papers that it's 10 days above the national average. I just wondered what the plans, why is that, and what are the plans to address it?
And thank you. And if Vanessa were here, she would be saying they've given themselves the most stretching target in the country to reduce the length of stay. Jonathan, do you want to give a few more details?
Yes, so it is differential between South London, the Maudsley, and South West London and St George's. And I think with South West London and St George's facing a bigger challenge, South London and the Maudsley are at the median London average position for length of stay. Whereas South West London and St George's, as you highlighted, are significantly over. And as Mike has said, there is a plan through the course of this year to get back to that target. We're expecting a bit of a hump early in Q1 because there are some very long length of stay patients who are due to be discharged, which will skew the numbers. When talking to Vanessa about it, and she would talk more eloquently than me, Anne, about it, she highlights some of the challenges, for example, through the Ministry of Justice around getting some of these patients out in a timely way. But I think with the rigour that we put in place across the ICB last year for physical health patients, I think we're now trying to do the same for mental health patients, because it is a key part of delivering the productivity ask that the trust is able to achieve the reductions in length of stay that we need. And I hope that will help with some of the challenges we see for patients in crisis. It's also how we're spending one of the few areas of investment in the mental health investments funded this year as well, which is an important part of it. So hopefully that gives a bit of a flavour of it, but we'll talk more outside with Vanessa if that would help.
Yeah.
Jacqueline.
Thank you, and thank you for asking that question, Anne. I think just to say, number one, I think South West and St George's have absolutely really put their shoulder into trying to get patients with a purely mental health problem out of ED as quick as possible, and we've certainly seen a reduction in the amount of patients from South West London and St George's in ED. I do, though, just want to mention Epsom, who, whilst in Surrey, is also part of it. And we have had serious problems with SABP, Surrey and Borders, trying to get patients out. And in fact, they've had some of the longest length of stays in ED in the country, as well as have, I think, one of the longest length of stays in their own organisation. And unlike South West London St George's, who don't tend to admit patients who need what they call an informal admission, they'll only tend to admit patients or people who with a mental health problem that requires sectioning. That's not the same in SABP, and therefore we have some different issues there, but we've collectively tried to address those as well, and they have seemingly got a bit better of recent note. But I just wanted to mention that as well, if that's all right, Jonathan and Mike.
Catherine, no, thank you. It gives a much richer sense of the challenges that we face across the whole of the system and across all of our hospitals. We will move on to Audit Risk Committee, and as I mentioned at the beginning, Martin has retired from the ICB, so I'm going to go to Helen straight away for this. Helen, to you.
Thank you, Chair. So we had the last audit committee meeting at the end of March, with an initial focus on reviewing the BAP and looking at place risks, as well as having a detailed discussion around the financial sustainability risk. We did receive the draft annual report to be able to comment and review, and looked at the annual accounts timetable in line with the external audit plan, with also receiving updates from internal audit and counter fraud. We had a detailed discussion around the Procurement Act that came in at the end of February, Originally, all of our procurements used to be under the old PCR rules. We currently now have procurements under PCR, PSR, and the Procurement Act. So we're running 3 different procurement processes depending on the type of procurement that we have. So we're just trying to manage that and mitigate against making sure we use the right appropriate routes. And finally, we looked at the policy and updates around conflicts of interest. But happy to take any questions.
Thank you, Helen. Any questions for Helen in relation to audit and risk? In which case, we'll note all of the board reports and we'll move on to item 10, which is any other business. I have not been notified of any other business. Are there any pressing matters from members of the board that they wish to raise at this point? I don't see a flurry of hands going up, which moves me on to item 11, which is meeting close. So as there is no other business, I will close the meeting. This is the point where we would take public questions. We have not received any public questions, and a reminder for any members of the public watching, please do submit questions by email in advance of our next board meeting. Our next meeting in public will also be on Teams, and that will be on the 15th of October 2025. So colleagues, please do have a good summer. I'm sure I will see all of my colleagues on this call between now and the 15th of October. Thank you all very much. I will close the meeting now.